23-24, National Trainer for POXO, WHO, Government of India, IMA Project on POSCO Act, National Convener on IAP Project on Child Rights, Safety and Child Protection. He's got good publications on Handbook on Child Rights and Safe Childhood Right OD Every Child. Our past National Vice President, Dr. Rajiv Seth, used to talk a lot about him and his contributions to the field of child rights. So, welcome, Dr. Ashok, sir. Welcome.
Thank you. Thank you.
And I'll request you to introduce our speakers, sir, Dr. Arun Inamadar.
Thank you, Dr. Alok, Dr. Arun, Ajay Gupta, and other dignitaries on the panel as well as on the platform. I'm extremely thankful to Delhi IAP for inviting me for the last module program on the e-certificate course in pediatric dermatology. As you know, in pediatric practice, around 10 to 20% of patients will have some dermatological issues, which mostly looked after by the pediatricians. No need of a separate dermatologist for that. And it so happens quite often a child will be brought to you for an intercurrent infection or something like that, or immunization, and in the last minute they say that yes, doctor, there is a small white patch on the back of the child. What shall we do? So the question is whether we should ignore it and say, okay, fine, it is fine, it will be okay, or you have to say that sometimes you may miss a major problem. So looking at the dermatological aspect is very important for a child health point of view. In the MBBS period and all, we start with our clinical examination after history, inspection, palpation, percussion, and auscultation. And I have never seen any of the dermatologists doing any percussion or auscultation in my lifetime. But inspection is the most important thing. Palpation very rarely. In that context, I think today's topic is absolutely fantastic. And as you say, if your mind or your brain doesn't know, you will not see. And seeing is more important in dermatological practice. And we have a right person to lead us to the what you call the pictorial area of dermatology. Dr. Arun Inamadar is a well-known person in dermatology. Is the professor and HOD of the Sri B.M. Patil Medical College Hospital, Bijapur, Karnataka. And he has a lot of publications, more than 250 publications. He has a lot of awards also. And his main area of interest is pediatric dermatology and critical care in dermatology. I'm extremely happy to welcome and introduce Dr. Arun Inamadar, and I request him to go through his pictorial journey through pediatric dermatology. Over to you, sir.
Thank you. First of all, I'm really thankful to Delhi IAP for considering me for this e-certificate course in pediatric dermatology. And I have been associated with your IAP even the previous year also, when Dr. G.C. Basavaraj from Bangalore and Dr. Atul Kulkarni from Solapur were conducting similar lecture series. In fact, I have given 2-3 lectures in that also. So my love for pediatric dermatology as a special interest other than the medical dermatology is actually ignited by the pediatricians who are practicing in my place. So they would pose these scenarios of cases where I have to learn so that I can answer them. So that challenge made me a better pediatric dermatologist rather than just a dermatologist. Well, today I'll be talking on some spotters in pediatric dermatology. As you rightly told by Professor, the senior pediatrician Ashok Kumar sir, that it is inspection, and inspection, which is a visual specialty, especially the dermatology, and especially in pediatric dermatology, where attender also may not give the correct history also. So that way I thought, instead of putting tougher cases and all, not just showing the knowledge, it is sharing the knowledge. I thought whatever has been discussed, all these 14 modules or the 13 modules, I just again refresh them with the pictures and some pertinent questions so that we'll revise whatever we have learned. In fact, I should have talked to the Alok Kumar sir or our coordinator how we should have gone for these quarters. But anyway, if there is a chance next time, probably we should have a question answer session wherein we find the nearest possible answer and how we differentiate it. Well, that's not possible now. Anyway, I will try to make it as better as possible. Let me start sharing my. Well.
Yes, screen is visible.
Okay, I'm just trying to move the slide. Well, let me start with this spotter number 1. Here, there are 3 children of a similar presentation. The lesions are dermatitic lesions over the cheek and forehead. Interestingly, the part of the nose is not very much involved. This is a very important point when you differentiate between a disease, a dermatitic disease, or any genodermatosis with photosensitivity, where invariably the nose is spared. Here it is subacute dermatitis over forehead and cheek. Yes, I know the diagnosis is atopic dermatitis. When do you diagnose? Well, it is a chronic or chronically relapsing inflammatory dermatitis, manifest usually in infancy and childhood, and it grows with the age. This is an important thing, because in atopic march, what happens? Maybe around 7 or 9 years, this atopic dermatitis comes down and it takes over to the allergic rhinitis or asthma or any other conditions. It will have 3 phases, which you know, infantile, neonatal, and the adult phase also. Then these are some criteria for diagnosis of atopic dermatitis, which we use, but the big list of 23 minor criteria and 4 the major or the basic criteria. So these are all just manifestations which we can correlate and make diagnosis. Many a times what happens in children, what I have found out is atopic cheilitis, nipple eczema, and Pityriasis alba, which you see quite often. Sometimes the follicular accentuation, which we see as a keratosis pilaris, are also a part of atopic dermatitis, which can give a clue for your diagnosis. So these minor criteria, the Denny-Morgan fold, all these things should be remembered. I would put it cheilitis, nipple eczema, which are usually not observed. So they are all part of the atopic dermatitis. Next comes one of the thing is the crust. It's a secondary lesion actually. A crust is a dried out exudate. Here in this picture, you can see a dried out exudate. Well, I don't know how many will be thinking. I can give a clue that it is honey colored or golden yellow. So a possibility of impetigo is usually thought. Whenever you find, yes, the clinical clue is golden honey colored crust are very much characteristic of impetigo contagiosa, and the cause is Staphylococcus aureus, sometimes group A beta hemolytic streptococci also. And sites, usually wherever there is a staph colonization is seen, especially around the nares, or already existing dermatosis such as atopic dermatitis, the staph colonization is much. And sometimes what happens, dermatitis, the atopic dermatitis will have a yellowish crusting that is called as impetiginization. So unless you treat with antibiotics and then the necessary treatment for atopic dermatitis, response would not be there. So these are some clues or the way by which you can manage the secondary impetiginization also. So clue is honey colored crust. Yes, it is impetigo contagiosa. Then I will show you some speaking image. When we had a case with a skin lesion or the right external ear, referred from Department of Pediatrics for our opinion. Well, this was the picture. All of you can see here in external ear, you have got a thick crust. We can almost call it as a scar. A dark adherent crust is there. Incidentally, when I was seeing this child with the cell phone itself, I was taking the pictures because it's very difficult to take get the concentration or the attention of the child to us. I was just taking picture. Child was about to cry or in the process of crying actually. I could see these changes. So there's a famous saying by Sherlock Holmes, just don't see, but observe. So if you observe this child with the serial photos which I have taken while examining the patient, you can obviously see facial palsy. So now the diagnosis is different. That is malignant otitis externa. Malignant, it is a misnomer. There is nothing malignant, but it is caused by Pseudomonas aeruginosa. And you can also, in some cases, aspergillosis can also be thought. But here it is a Pseudomonas aeruginosa, which is called the otitis externa. And you know the treatment very well, more than the dermatologist. But why it happens? Well, the facial nerve, the cranial nerve, which may be involved and manifest as a facial paralysis. If the infection spreads to the stylomustard foramen, where the cranial nerve 7 exit the skull. So that's why the case was malignant otitis externa with facial palsy. Then this has to be differentiated from the ordinary ecthyma compared to the ecthyma gangrenosum. Simple ecthyma, I just showed you impetigo. If the deeper part is also involved, or the deeper extension of the untreated impetigo or folliculitis is there, you get a pigmented crust. And what is the difference between this crust and what you see in ecthyma gangrenosum is actually in a real sense, the ecthyma gangrenosum lesion is not just crust, it is a scar. Whereas ecthyma, it is a dried out exudate with admixture of blood and the other material. That's why it is pigmented. And if you press underneath, there will be pus which oozes. And if you remove it, punched out erosion will be there. Whereas in ecthyma gangrenosum, which is due to the Pseudomonas bacteremia or with immune suppression, it is characterized by hemorrhagic papule that progress to bulla and ulceration with dark adherent excer. And if you press, there is no oozing of the pus or anything. So these are small things by which you can make a difference between two conditions. Then the next comes grouped vesicles. So whenever you find grouped vesicle over an erythematous base, it is a spot diagnosis that it has to be herpes simplex. Any grouped vesicle over an erythematous base, usually caused by HSV1 and HSV2. And you know HSV1 infection seen above the waist, and HSV2, that is herpes genitalis and other things below waist. And they are always present as a grouped vesicle. And usually the primary episodes are associated with constitutional symptoms. One of the characteristics of herpes infection is recurrence. The patient says, often I get to the same site. And what happens over a period of time, the severity decreases. You may find only 1 or 2 vesicles, or patient may feel some itching, some burning sensation, after which he develops small lesions. What is important in children is sometimes this herpes simplex infection of the lip is associated with another condition called as erythema multiforme minor. Some target-like lesions will be there over the body, especially the acral part of the body. And it is recurrent, which I have told you. And if the same thing happens in neonates, it is a medical emergency. Then you have to have IV acyclovir and other things. Well, the similar thing, if the same grouped vesicles are over an erythematous base in a dermatomal pattern, here it is the mandibular, the maxillary nerve, which is the dermatome, and you have found the disease. Very simple, that is herpes zoster. Well, it is caused by the reactivation of the varicella zoster. And what is the clinical clue? A grouped vesicle or an erythematous base in a dermatomal distribution. Extremely painful, that is zoster associated pain. And sometimes once it heals, especially patients above age of 50 years, or very severe infection at the start, or underlying diabetes and all, post-herpetic neuralgia is seen. But in children, invariably, these are not seen. And then another one, a spotter which you can see in your day-to-day practice also in children, which is very common, is a skin-colored lesion, which are umbilicated, and they are like almost pearl-like thing. And what is important is each pearl-like lesion, you have got umbilication in the center. So this is very classical picture of Molluscum contagiosum. Well, it's a self-limiting epidermal viral infection caused by pox virus, spreads by autoinoculation. That's why you get good number of lesions. And treatment is by needle enucleation, or sometimes we use topical 10% potassium hydrox to be applied every night, and it dissolves the keratin and dissolves that. The clue here is pearl-like lesion with an umbilication. Well, similarly, you can also find elevated lesions like this with a surface which is verruciform, that is viral warts caused by HPV infection. And what is clinical clue? It's a hyperkeratotic papules of plaques which are discrete, and it can be multiple, and it can also manifest as a solitary lesion. So this warty surface, what we call, and sometimes distate and filiform lesions can also be seen. And if you see carefully in these warty lesions, you can find thrombosed vessels looking like a dark spots. This is how you differentiate between if they are over the, especially the soles, whether it is a wart or just a callosity or a corn. So this is how you differentiate. So this is a common the viral infection, and usually asymptomatic. Usually it has to be destroyed either by electrocautery, or can use the cryosurgery. And nowadays we use immunotherapy. Even topical BCG can be applied over a period of time. You can inject the BCG into the lesions, and reduction is seen. So that is called as immunotherapy. Well, sometime what happens in skin, how do you make a diagnosis? Distribution and very typical lesions are very important. In this child, the child has a very big lesion like the one which I shown on the left-hand side of my presentation. And another area where you got multiple the daughter lesions we call, this is the mother plaque and these are the daughter lesions. They are very typically seen between neck to knee only, from neck to knee only, and they call it as, of course, the diagnosis is Pityriasis rosea, self-explanatory. Begins with herald plaque, which I just told you, the big lesion, and then there will be daughter lesions. They are called as, they will be distributed from neck to knee as Christmas tree distribution. And this is very classical Pityriasis rosea. Sometime what happens, a big lesion like what I showed you as a mother plaque. But nowadays you must be seeing a lot of these cases. What is important is the central area is very clear, and the border, if you see carefully, you've got an active border with papules, vesicles, and sometimes scale. This is the dermatophyte infection, that is fungal infection. So now it is an epidemic, and many of the drugs which we use has to be given for a longer period, for a lower, the dose also has to be increased. So what is more important? The leading edge, active border, scaly, red, and slightly elevated to the central clearing, which is very much important. Well, This is classic ringworm pattern we call, nothing to do with ringworm per se. Well, the treatment is a very difficult thing now. Well, if number of lesions are less in children, we give the topical luliconazole or any topical antifungal agent. If there are more number of, then you are compelled to use either the systemic drugs like itraconazole or griseofulvin or terbinafine. Well, nowadays even terbinafine doesn't work. It's a difficult thing, but we usually manage with the topical luliconazole or other oxyconazole, other molecules. Why I showed these two lesions when the mother plaque and this is to differentiate the border and the daughter lesions which are seen in Pityriasis rosea. The other one which are very commonly seen as a dermatological manifestation is papules and plaques with silvery white scales. Well, when the word silvery loosely adherent scales are there, it is psoriasis, which is a chronic plaque type. Yes, you get a distinctive red scaling papules that coalesce to form round to oval plaques. These are the clinical clues. I already told you, silvery white, loosely adherent scales. And if you have got a slide, that is the glass slide, we just keep removing the scale with the slide, you get a pinpoint bleeding spots of the dilated vessels in the papillary dermis on grating the lesion. If it is positive, it has to be psoriasis. But in children, what happens is, it is not usually the only chronic plaque type. It is teardrop-like lesions over the trunk and other things. They are called as Guttate psoriasis. What is important is teardrop-shaped spots. It does not normally leave a scar, usually seen in children and young adults. One important thing about Guttate psoriasis, prognostically, it is very good one, because invariably it is precipitated by streptococcal infection. A course of antibiotic is given, and the rest of the other treatment, what is given for psoriasis is given. Invariably, lesions remission will be there for a longer period, and sometimes it will not recur. So that way, psoriasis in children, especially when they appear like the Guttate psoriasis, not psoriasis, a plaque type, when it start early age of infancy and all, they will be more severe, difficult to manage because it keeps recurring. So this is one good thing about Guttate psoriasis. Sometimes what happens is, you get in the flexures, they are called as flexural psoriasis. What is important here is to differentiate between other diaper dermatitis or candidal intertrigo. Here, the whole concave surface is involved, whereas in diaper dermatitis or the irritant dermatitis, the folds are not involved, only concave, the convex surface are involved. And red glazy patches, not only here, sometimes the axilla, the other folds can also be involved. And if there are satellite pustular lesions, then it is candidal intertrigo. So that way, this spotter will help you how to differentiate between the dermatitis seen in the crural area, whether it is diaper dermatitis, whether it is flexural psoriasis, or whether this is candidal intertrigo or just bacterial intertrigo also. The other one which you can also see in your OPD is the flat-topped lesions, which are violaceous in color, usually referred as Lichen planus. So they are classically having 6 P's. They are flat, that is planar. They are purple. They are polygonal. They are pruritic. They are papules and plaques. If they are, what is important about these things is, if they are localized or very few lesions, well, some topical steroid would help. But when it is an acute eruptive lesion or a generalized lesion, invariably the better to be managed by dermatologists. They may use, usually they use, or we use the methotrexate in pulse therapy for about 3 months or so. or sometimes very severe lesion, oral corticosteroid, short pulse, or sometimes we use narrowband UV therapy, or many more options are there. Sometimes when to refer to a dermatologist is also an important thing, I believe, as a consultant. This is where you can diagnose, try your best in only localized lesions and refer to the case. Sometimes you find these pictures in children. Well, it is very commonly seen by you people, unless it's a very chronic one or extending to the other parts of the body, then you refer it. That is infantile seborrheic dermatitis. They are greasy scaling rash compared to the dry, adherent, loosely adherent scales of psoriasis. They are in seborrheic areas, scalp, eyebrow, front of the chest, flexures, that is crural area, interscapular area. What is important as far as infantile seborrheic dermatitis is concerned, if it is not responding, if it continues to develop, if it is severe, generalized, it can be presentation of underlying primary immunodeficiency. And if you find seborrheic dermatitis with a component of hemorrhage into the lesions, well, if you just palpate abdomen, you can get abdominal, that is organomegaly. Invariably, it will be Langerhans cell histiocytosis. Just do not neglect infantile seborrheic dermatitis if it is recurrent, severe, generalized, associated with some hemorrhage into the lesions. So this is where recognition of seborrheic dermatitis is important for the diagnosis of other conditions. A primary immunodeficiency, one of the thing, and LCH is another thing. Well, there was some discussion regarding by Ashok Kumar sir that sometimes you get a hypopigmented patch present since birth. It is not the child, it is the attender who come, not only mother, grandmother, and whatnot. So they will be worried. The first question is, as soon as we see, if we say it is not vitiligo, they will be relieved. So they want to know whether it is vitiligo or not. If you just see this case, all the lesions have a different size and shape. What is more important is irregular outlines. In all the cases, outlines are irregular. So this is very much characteristically seen in Nevus depigmentosus. They are present at birth, stable in size and shape, irregular outline. I will repeat this: stable in size and shape, irregular in outline. Next point is very much important, that is size increases in proportion to the growth of the child. What happens is, invariably, we diagnose at the early part of their life that, okay, this is nevus, nothing will happen, it is not going to harm your child. Next few days or months, or in 6 months or 1 year, the parents will bring the child and tell that, sir, it is increasing. So we are telling it is birthmark, how can it increase? So it was a kind of thing which we kept on explaining how to best we can explain. I was just trying to explain in a way, this is how I tried my best way. And I just used used pen and took a balloon and marked as in deflated balloon as a nevus, and I blow the balloon and I showed them balloon size is increasing, that is body size is increasing, and proportionately that nevus is also increasing. Then they were convinced. Many a times now we often use in our OPDs, and many of my friends in dermatology practice use this thing to tell it. Interestingly, I published this in paper in international journal, Pediatric Dermatology, proportionate growth of congenital nevi, blow a balloon to explain. Though sometimes very simple observation which you use to convince the patient can be shared in journals so that other colleagues can use it. So this is so simple, but this is how you can explain to them. These are the two different things. One is, of course, here also it is streaks of depigmentation is there. Here very classical segmental part of the body is involved. And as I'm referring you, See the border, there is not irregularity. Convex borders are there. Here, irregular borders are there. There are two different cases. One is segmental vitiligo. Another is a form of hypomelanosis of Ito, otherwise called as streaks of pigmentation, hypopigmentation. Nowadays, we call as pigment mosaicism, to put everything in one nutshell, whatever with the checkerboard pattern, linear lesions, very few lesions like Nevus depigmentosus. But one concern or one thing we always ask is any association with neurological manifestations. Sometimes they may have a history of epilepsy or seizures in childhood. That has to be taken care. That's why we call a whole nutshell as a pigmentary mosaicism, whereas streaks or phyllide pattern of hypo or hyperpigmented lesions along the lines of Blaschko's or the lines of ectodermal embryological dermal are seen. Not only hypo, you can also get hyper also. So, but classically you can get segmental vitiligo. Very classical lesions, convex borders, and once the treatment started, even the very marginal pigmentation is also seen. So, one of the important thing to differentiate between the hypomelanosis of Ito or the pigment mosaicism and segmental vitiligo is very important in early childhood because of the parental anxiety. The treatment varies. You don't have to treat anything. Assurance is enough for hypomelanosis of Ito unless there is a history of seizure. Well, that has to be maintained. I don't have to tell much about these things because it is just a spotter type of discussion. So what is important? Convex hyperpigmented border is very important. Before I close the talk, I will tell one more speaking image case. Well, a 4-day-old neonate presented with ill-defined dark blotchy pigmentation over the face with more prominence over the centrofacial area. I think many of you must have got the diagnosis by this time. But what is more important is history. Mother had a history of fever starting a week before delivery and continuing for 3 days in the postpartum period. The empiric diagnosis was congenital chikungunya because mother had fever, joint pain, even other family members also had chikungunya history. Investigation, immunoglobulin M antibodies to chikungunya and mother and child were there. The diagnosis is chikungunya, congenital chikungunya. So if you see blotchy pigmentation in a child newborn, just ask the history, probably you will be right, and it will take its own time and disappear also. Well, I don't know how much I have really done to this session, but I thought to make it very simple, whatever you have learned only, I have just revised with some clinical clue so that we can recognize them better. Maybe next time I would go further to have a real case scenarios like speaking image that I told you. I have a good number of cases, but I thought spotters, it is as soon as you see, there has to be a clue and diagnosis.
So we'll have a
so that way
that sometime in the future.
Thank you very much for giving me an opportunity.
For an excellent presentation. You have led us through the dermatology, which common, I think most of the common problems we pediatricians see in our clinical practice has been covered, especially in a very good pictures which remains in your mind. That is more important, that it should be there as soon as the child or you see the lesion, you should recognize it. And it was an excellent presentation and beautiful photographs. Thank you, sir. Thank you very much for an excellent presentation. And now the session is open for discussion. We can have any questions if there are any questions.
Can I make a comment, Asokma, sir?
Yeah, yes,
Sure,
yes.
sir.
Okay.
Sir, it was an excellent presentation. The two images, that is the speaking images, what it is rightly pointed out. The first one with the malignant otitis externa with the facial illness. we all heard about Ramsay Hunt children involving the trigeminal area, and this is the seventh. This message is new also to some of the even to me, the malignant impetiginous lesion involving the things. That is a speaking spotter number one. I thought was first to see. I thought it's a Pseudomonas infection. Anything in the smaller infant with a dark or bluish discoloration, we think of Pseudomonas infection. This is a rule of thumb. Then the second one, of course, is the congenital chikungunya. This is a speaking spotter also. Very alarming, very, very alarming, and the child is very irritable. 2009, I remember there is an outbreak of chikungunya. Even I suffered. And still now I am having that arthritis issue because of the post-exposure. So it's a very painful condition, and it is manageable also. So these two, all the other spotters are excellent, sir, for our practicing pediatrician. And I love to listen to all this dermatological because, as Dr. Ashok Kumar mentioned, even yesterday during my immunization practice and the regular consultation, one with the baby with a small blister that is in the lip, and another one with this hypopigmental lesion. They always come for different problem and they show a dermatological problem. 100% it is around 10 to 15% it is associated issues where the general pediatrician must update about this and make their knowledge good. Thank you so much, sir.
Thank you, sir. Thank you, Dr.
Some questions are
Sir,
there,
one delegate has asked, sometimes we get young children coming with generalized itching, mainly in the legs and at night, without any rash. Itching is usually severe enough to disturb the sleep. What is likely cause and how to manage them? Dr. Anukriti has already answered, but sir, I would like to ask you, can we rule out scabies and atopic dermatitis in these cases? Can this be caused?
What I have, yes, the first thing is scabies. Invariably, what mistake is done in treating scabies in children is, with due respect to my colleagues, pediatric colleagues, invariably you will not treat the other family members.
Yes.
So, well, it's a standard.
Especially if they don't have any lesions.
Because they also object. They tell her, "Mujhe hame kuch nahi hai." So you have, whether you have got or not, what I'll tell, within 6 to 8 weeks, you will also get better. You get treated, number one. And another thing which I have seen is iron deficiency children get itching.
Okay.
So that has to be ruled out. And only atopic child, sometimes atopic diathesis, only dry skin is there, and just liberal application of an emollient would work. Even simple liquid paraffin and a soft paraffin application would work. And there is one more question somewhere here that about the treatment of nevus depigmentosus, nothing to be treated. Sometimes they have attempted in dermatologists like the keratinocyte melanocyte culture application also is being done, but it's not convincing them is more important. And why it does not, it's not growing, but just a simple blow the balloon experiment should help them. And somebody has asked zinc or other mineral deficiency skin lesions. In fact, I would have loved to show all those things like acrodermis, enteropathica and all. I thought spotters, now for a e-certificate course for a basic pediatrician, I thought first let them recognize these things and manage the best, or refer when it is not necessary. And a complicated or complex cases, usually we interact with the pediatrician and then treat the patients. Zinc deficiency, very commonly seen, acrodermis enteropathica. Very classical thing is periorificial dermatitis. Wherever there is orifices, you have got the dermatitis. And the dramatic response to zinc is a therapeutic test. You don't have to do zinc. Of course, in the institution level, you have to do it. For a practitioner, even if he gives doubts and give it within 3 days, the irritability will go within 24 hours and the lesion should disappear within a week or so. In a practice, of course, you have to do these things also, not very much like an institution, ye kara do, baad mein dekhenge. That's also.
Sir, in North India, because of the severe winters, I have seen many parents use woolen clothings, which again irritates them very much.
And what I heard from my the friends from North India practitioners, dermatologists and all, A sarson ka tel also is not a good thing to be applied. On the contrary, it is either coconut oil or a simple emollient would be better. Olive oil is fairly better, but sarson ka tel actually can increase the and application of besan while bathing the child and all, that also increases the dryness. All those cultural practices also has to be thought, and what is regionally or geographically available methods by which they clean the child or apply these various oils also makes some sense while taking the history.
Sir, sorry to one interruption, sir. You just mentioned
Yes,
about the olive oil. In our derma module, as a pediatrician, we always said no to olive oil and mustard oil, sir.
That's why I'm telling you, no, I would go with coconut oil or just liquid.
Yeah.
I'm just giving the grading. If you at all you want to use, okay, use coconut oil.
Because the public,
Olive
they are
oil,
fascinated with the olive oil, you know, the olive oil meant only
It's
for edible use.
Yeah. And also see those, I'm just out of discussion. So whatever is eaten or used is depending upon the availability geographically. Because olive is there in Europe doesn't mean that we also become, if we eat Mediterranean food, we will also become best. It is not so. And in Kerala, everything is, the coconut is for everything. Sarson ka tel in other areas. In other part, the Karnataka or the Maharashtra, we use the peanut or the other oil. So they are all, I don't think just because it works in Europe doesn't mean that it should work here. And there are studies where, I rightly told by you, they have compared coconut oil, olive oil, and other mineral oil also.
Mustard oil.
Mineral oil is a better thing.
Sir, Dr. Nitin has asked the dose of oral fluconazole in tinea corporis and tinea capitis. Should it be weekly or daily?
No, it should be daily. Unlike you give in the pulse therapy for other things.
Sir has extensively used the speaking images. Actually, I was expecting red flag speaking images like TENS, SSS, and Stephen Johnson, the erythema multiforme. But that is a very vast one. And actually, I was expecting, because these are all the speaking images in ER room.
Actually, these are the common OPD presentations.
Yes. No, I sorry for that. I didn't discuss with the coordinator. What they want is more important. I may be having, like, I can talk on speaking image.
Actually,
I can talk in emergency in dermatology, emergency in pediatric dermatology. I have collections. It is not I. It is just to share
Dr.
the knowledge.
Kavita has asked any treatment for viral warts. Does local application help?
Yes, even the topical salicylic acid or topical retinoic acid, if they're very small ones and not of a long duration, not of a chronic nature, the idea is to destroy. How you destroy it? Physical method, chemical methods, or immunotherapy. These are the ways by which we can do it. And if you don't do also, it will go on its own by 2 years, but that you cannot tell as a doctor.
That's a long question.
Well, sir, Dr. Jalil, sir, the concept, it would have been like, if the title was spotters, then I thought of this. And little complicated, herpes with EM.
It's rightly mentioned as a speaking spotter. Good one, sir. As you see, you have to come to the diagnosis and start treating like that. It is the first time I'm hearing the speaking spotter. Good one, sir.
I have a good, I used to, there is a speaking images in dermatology, and this is one more cases in search of diagnosis, where how difficult it was to make a diagnosis, and somehow later they got the diagnosis. So the same thing, but
question,
how you...
One 80-year-old female patient gets severe rash only on the back of the thighs. IG levels are high, gets controlled with antihistaminics, but recurs on stopping. What can be the cause behind?
There are two things. One is, if it is an acute urticaria, sometime you can use very severe one, a short course of steroid and antihistaminic. not in chronic urticaria. If the duration of the lesion is more than 6 weeks, if it keeps recurring, probably it is a chronic urticaria. Not less than 3 months, you have to supplement the antihistaminics for a suppressive therapy. And after 3 months, in about 90% of the time, invariably that will be subside. But it is like it's an atopic thing. Like asthma, sometimes there will be exacerbation and then remission will be there. Suddenly there will be again, and then you treat it like that. It's like any other the allergic or the immunological manifestation which you see. People expect, or the doctor also should not think, okay, my ache, I will give it for 4 weeks, it will go. It is not like that. It is a clinical reaction pattern for some causes known, and that is not known, then idiopathy. So if that is the case, you are treating the symptom. So how long? How long? As long as you want response. How much I should give? The dose, minimum dose by which you can suppress the manifestation. So these are certain things which over a period of time, your practice, people will understand how best we can use the medicines.
Sir, how common is the food allergy manifestations on skin?
Not exactly. There are, studies where like very specifically egg or cow's milk. Otherwise, not very much. The
Presenting
other things,
as urticaria also.
very rare. What I have found out is the food coloring agents. So some, like I will tell you, some preparation called as chicken 65 or some 65 where the color is added. Hara bara kebab, but what green color where really it is a food grade color, it is fine. Sometimes they can also cause. So the coloring agents or the ingredients used in the ready food or the packed foods can cause. Otherwise, simply blaming brinjal, I eat this okra, that bhindi, and then I get. If that is the case, what I would tell is stop everything for, eating those bhindi for about 10 days or 14 days. You eat every time. If you get, then only. Otherwise, always it is just incidental. Coincidentally, they think my ek khaya, ye ho gaya. Aisa nahi hota. It's like just.
Ajay sir,
Yes,
sir,
sir.
yesterday there was a flashing news in Delhi. The hostel girls, they asked for a birthday cake, ordered the birthday cake. Once she consumed, become an angio, and then suddenly collapse before intervention can occur, sir. It was a news yesterday from Delhi, flashing news.
This can be, I think, can be even foreign body aspiration kind of thing. Otherwise, happening at such a pace is very, very
pace,
and without any questions of allergy also.
Yes, sir. There's a question when to treat cradle cap, treatment options and durations.
Well, you can treat with very mild tar-containing shampoos, and even the topical cycloparax olamine or topical ketoconazole, because it is exacerbated by the fungal element there, so you can use it.
Yes, another question is, are biologicals used in India for atopic pediatric dermatological conditions? Biologicals.
Yes, dupilumab is being used above the age of 6 years or so. There are other lot of good medications available also. So only there's a last resort. And it is not that, it is again not a panacea that, okay, once you use it after spending so much, is it the end of the story? No, it is another option for treating chronic resistant where you have exhausted all other armamentariums.
There is the latest medicine called chrysosome, which is not either the biological nor a antihistamine.
I know, I got it. It is crisaborole. It is something just for mild and moderate atopic dermatitis.
Yes, sir.
It's as good as using an hydrocortisone also. lot of
I have tried
what
in
is
few
happening
patients,
in
but the response
therapeutic,
is good.
only mild and moderate you can use it. See, what is happening is
Mild and moderate.
newer therapeutic agents are developed for the targeting one or the other inflammatory cascade. So somewhere
Yes,
it will
sir.
help for a period, and that's how things, small molecules like JAK inhibitors, phosphodiesterase 4 inhibitors, one of the apremilast and the other things. Like there are many things. Good thing about being a dermatologist now is, compared to the 30 years back, is I've got good molecules for giving at least good quality of life. So that is the difference, what was there 10, 20 years and it is now.
One of the major confusions in the mind of pediatricians is the duration of treatment, especially with the antifungals. What is the ideal duration? Because they are always...
Actually, ideally, I'll tell you, ideally is very simple. If you know the basics of epidermal turnover time, it is 4 weeks, and only the dead it is a dead, it will be there in the dead layer, that is stratum corneum, only 2 weeks. So once you start the treatment, clinically you see there is no lesion, then also you must add plus 2 weeks to take care of the one cycle of the stratum corneum. That means till clinical lesion subsidence plus 2 weeks is the ideal treatment. Now, well, it may take 4 weeks, 6 weeks, 8 weeks. So what is the method you see after? It all depends on how much you can convince the patient. Can you see after 4 weeks? Can you see after 6 weeks? I would suggest after 4 weeks, see the borders, whether they are completely cleared. In the center also, around the hair follicles, fine hair follicles, if there are still lesions, that means it is lurking, infection is lurking. Continue for another 2 weeks and see complete subsidence, then only topical for another 2 weeks and stop. It's evaluation clinically, not that you keep doing KOH and see whether it is there or not. So duration is, I will put it in a simplest word. First criteria, as long as you want the clinical response, that means you know this is the clinical response after. As long as there is no obvious side effects, as long as you use the antifungal or antibiotic, the least mentioned dose for MIC, or anti-inflammatory conditions like various steroids, methotrexate, MMF, or any other drug, least dose which can give the best results. Or duration, sometimes methotrexate we give weekly once for psoriasis. Once I find very conducive response, I may make it every 15 days once I can make it, till I get the best maintenance dose by which you can get the subsidence of the infection. So only in antibiotics, okay, you say this much is the duration. Otherwise, all or it is a response with which we want to know. Or you take anything, immunology you take, rheumatology you take, oncology you take, response, how much you want to have the clinical response is the question. No? So how can you say I will use it for warm? But for everything there is a dose schedule. For example, I use cyclosporin for severe atopic dermatitis. If I use 3 months, if there is no response, I will stop it because it has not acted. If I start azathioprine, I know for 6 weeks it will not give the desired results. So you should know the pharmacokinetics and when they really give the result, and after which if there is no sufficient result, expected result, you have to stop it. That's why there are always first line treatment, second line treatment, third line treatment, adjuvant treatment, additional treatment, and whatnot. So treatment planning or the therapeutic planning is a most tricky issue, but understanding the disease, understanding the molecule, understanding the prognostic factors, understanding the comorbid conditions when you use a drug, makes sense. So duration should never be asked in any forum, in any qualified professional meetings, except, okay, post-graduation, that is a first-year student, because he will not know how much to do. But by the time he comes to second year, he should understand it. So if you know what disease you are trying to, either it is infection, whether it is inflammatory condition, is it a benign tumor or a malignant tumor, or a rheumatological conditions, or a whatever you say. So it is understanding of the disease, understanding of the molecule, and interplay of all those makes or gives an answer for your duration, dose, when to stop, when to add, when to do baseline examinations or the baseline parameters, and when you should repeat those tests depending upon which organ is invariably attacked by that molecule which you are using. And some things in children, okay, cyclosporine when I use in adult, I am always worried about hypertension, kidney toxicity. I do blood urea, serum creatinine, and other things. In children, invariably the nephrotoxicity is less. What I have learned, I'm not an expert, because I used in one of the cases where the pustular psoriasis was there also, and a steroid-resistant nephrotic syndrome was there with the child. I had a beautiful picture. Maybe sometime, when God willing, we'll share those things also. And cyclosporine works because it works for both. So it's a fine balance of understanding the whole gamut of the armamentarium and the disease with which you are fighting.
So, Dr. Ashok Kumar, sir, any other questions you would like to ask?
Not much, sir. Almost all answered.
I don't think Dr. Inamadar has left any query unanswered. The talk was self-explanatory and it was a real treat, sir. A grand finale of this academic module of dermatology, and we would like to see you soon, sir, in further our modules. And Dr. Ashok, sir, with your interest for child rights, we will also like to involve you in some our child rights activities and all. I'll discuss and we'll have you with us on board.
Yes,
and
sir.
Dr. Jalil, sir, for neonatology, yes, we are, that is in the pipeline, and you are surely going to be our South Zone coordinator for that module. So,
Thank you, sir.
Thank you. And I have lost thanks to all of you for giving me an opportunity. And yes, Dr. Jalil, sir, I have
Thank you,
to
sir.
give a talk once more about speaking images someday.
Sir, we ourselves will
This
invite you
year,
for our
definitely,
platform, sir.
whether you like it or not, I
Fine.
will talk.
Coimbatore Zoom, I will arrange, sir.
Sure.
To all the
Love
faculty,
to chill.
our chairpersons and delegates for joining us, and we are really thankful to IP Delhi, Dr. Alok Bhandari sir and Dr. Mukesh for giving us this opportunity, and I'm thankful for all our coordinators, Dr. Anupriti, Dr. Deepika, Dr. Amit, and everyone who joined in to help us with all these sessions. And we are really thankful to all the faculties also. Thank you, Dr. Inamadar sir.
Namaste, sir. Thank you. Thank you. I will
Thank you, sir.
stop sharing, and thanks for
Yes.
all the.
Thank you, sir.
Thanks.
Thank you all. Ajay sir, thank you. Alok sir, thank
Welcome,
you,
sir.
sir.
welcome, sir. Welcome. Bye, sir. Bye. Bye. Thank you.